afternoon, Mr. Caskey. Good afternoon, Ms. Bennett. Right, when you're ready, Mr. Caskey.
Thank you. Would you tell the inquiry your full name, please?
Fiona Bennett.
And in what capacity are you here today?
Assistant Director Children's Services for Barnardo, Scotland.
Right, and at paragraph 4, you provide of your witness statement.
Yeah.
You provide details of your professional background and experience.
Yes.
I understand almost all of it, but I'm not entirely sure what GIRFEC is.
GIRFEC is Getting It Right for Every Child, which is a Scottish Government framework.
Right. Your witness statement is under reference SCI WT 0493 and then 501. You don't need to concern yourself with that. Okay, at paragraph 5, you explained that you've been an Assistant Director for Children's Services for over 10 years. And you go on at paragraph 8, well, after 7, where you say something about Barnardo's as a UK organisation, you then talk about Barnardo's as a leading children's charity, working with thousands of children, with over 100 base community services. Can you tell us a bit about that?
Yeah, there are over 100 community-based services in Scotland, ranging from early years family support right through to adoption and fostering and residential. In terms of justice, there are youth justice services, family support services, and services based in prison and in relation to community justice. And
do you have a particular responsibility in Barnardo's for the justice service? That,
I'm the Scotland Lead for Justice.
And what does that involve?
It means having an overview of the justice services in Scotland and linking with Barnardo's services across UK in relation to justice. Quite often I'm asked for my opinion in relation to justice services in Scotland and across the UK.
And are you involved in any of the family visit centres?
Not specifically, although my colleague is, and I have a good overview of what's involved with them.
The organisation does, but
yes.
You personally have a management or a leadership role in relation to that. Is that correct?
I've got a peer who manages that specific service, so right. I speak with her quite regularly, and I understand the visitor centre and how it works.
Okay, and you talk at paragraph 11 and 12 about your involvement with matters that may be of concern to this inquiry. Can you just say a bit more about those?
Yes, I mean, obviously Barnardo's works with the most vulnerable children, young people and their families across Scotland, so quite often they're impacted by negative experiences such as poverty, homelessness, etc., addictions, alcohol, drugs, and issues relating to child abuse, exploitation and things that may place children at serious risk of harm.
Now, paragraph 14 under subparagraph A, you talk about outside and youth work service. Can you tell us a bit about what it is that you do, HMPOY, Pullman.
His Majesty's Prisons Young Offenders Institute.
Yes, Pullman.
Pullman.
Yeah, we've been present in Pullman for probably in excess, since 2010, so 12, 14 years, and we provide a youth work service there, which involves potentially being available to any of the young people in Pullman, but individual work, group work and youth work, so activities around things that may be to do with their mental health and well-being, or activities such as arts, crafts, drama, that keep them involved and prepare them for life out with the prison.
Right, so it's part of a rehabilitative process, yes. Is that correct?
Yes, that's correct.
And then you talk about Inside Out.
Yes, Inside Out's a particular partnership with the Young People's Centre for Justice, CYCJ, that's really about engaging young people, hearing their views about the justice system, their experience have been with employment, and takes on board suggestions and recommendations about that to try and influence the environment that they live in there.
Right, and is that important to the young people?
It's important to the young people, but it's also part of the promise and the SBS's strategy to involve people in its care and the facilities provided to them.
And you talk about parenting matters as something else that's a significant part of your work.
Yes.
Tell us about that.
Parenting Matters is for young people and the women in Pullman who are parents. So it's parental support essentially to help them to consider their role as a parent. Sometimes it involves structured programmes. Most often it's just on a supportive basis so that they can better relate to their children in visits, in contact, or when they resume their care after prison.
So are you involved in people who have been in prison and are then being released?
Yes, yes. Our community-based services would quite often have follow-up work with people who've been released from prison and then offer family support and interventions to support them in their parenting.
And how was, this is a big question, but tell me about the impact of COVID on that work for people who were being, for example, released during lockdown.
Yes, I think obviously being released during lockdown was a different experience from being released pre-lockdown, in that it was quite difficult for people to get even from the prison to home. But when they got to their kind of home environment, a lot of the services were virtual and online at that point, so people needed support to access through phone or video support services. And for people resuming care of their children, they would immediately be resuming care within a lockdown experience. So all of the family would be living under the one roof. Children wouldn't be in early years or school settings, and that would have presented additional stresses for the person leaving prison, but also for their immediate family.
Okay. You say at 16 that COVID had a severe impact on people entering and leaving prison throughout their sentences and of their families, relatives, carers and those close to them. Tell me about the impact, firstly on going in.
I think on going in, the prison environment was very different during lockdown and the COVID period than it had been previously. So when people entered prison, they would have the things that we all experienced, the perspex, the hand sanitizer, the face masks, the social distancing, and all of those measures which were within the prison environment. I guess coming in, you're coming straight from court, and it was probably quite a shock to see that. Even for people who'd been before, they would have come into the prison and seen it as being very different. Similarly, they probably wouldn't have had much understanding of when they would see their family in the circumstances of lockdown and how that would be managed. And they immediately spent quite long periods of time within their cells, which was a different experience of prison than previously. Whereas I've described there may be other rehabilitative and social experiences that wasn't available to people during lockdown within the prison, and they're largely on their own for long periods of time.
Yeah, you say at paragraph 17 that the young people told us they had no idea what charges they were at court for, and how long they would be on remand or in custody. Just tell me about that.
Yeah, I think during COVID in particular, the court processes were disrupted, understandably. So people engaging with court had a very different experience. It would have been virtual. Some of the processes had been delayed. They might have not had as much support from local community-based services or solicitors and lawyers, etc. So they were very much more reliant on phone and virtual contact. For a lot of our young people, they may not have had a computer and ways to engage virtually with folk for that support. And they also have, they don't often they don't always have good literacy skills. So although written stuff may have been sent to them from the court and other sources, it's likely that they would have been highly reliant on face-to-face engagement to understand the court process and what was actually happening.
And was that, sorry, on you go.
And during COVID, that was restricted, wasn't it? It wasn't possible for people to engage with them in the same way, so it was very much more limited. And I think that led to a kind of them not always understanding why they were at court, what was going on, and what that meant for them, in a way that was quite specific to COVID. So they would have ended up in Pullman, sometimes on remand, for example, not knowing how long they were going to be on remand because the periods on remand were extended during the COVID period.
And once they arrived at Pullman, I think you spoke a moment ago about effectively the prisons being in lockdown as well. Tell me about that.
Yeah, that's right. Obviously, everyone within the Pullman and other prison environments needed to adhere to lockdown measures in the same way as anyone else. So, for example, previously, Barnardo's have young people in prison who are trained as peer mentors. So they would have met young people on arrival in the prison and been part of their familiarisation with what's going on in the prison from a kind of peer-to-peer point of view, but that wasn't possible within the lockdown situation, so they didn't have that benefit of other people in prison guiding them through the process, and they were relying on staff within prison.
Paragraph 19, you talk about bubbles being set up, but at worst, someone arriving in prison had no contact with anyone other than prison staff for long periods of time. Tell me a bit about that.
Yeah, I think especially at the beginning of lockdown, when lockdown was quite a new process for everyone, there was a tendency to want to keep people safe. So people coming in the prison were within almost isolation for quite long periods of time. If they tested positive as well, for example, they would be within their own cells for 23 hours a day and have limited contact for reasons of safety for other people associating with them.
Yeah.
As time moved on, that was able to be loosened a bit, and people were in these bubbles of 4 to 6 people. But obviously, if one of the 4 to 6 tested positive or was unwell, then it would revert back to isolation for the full bubble. So the 4 to 6 would go into isolation.
Did that lead to tensions?
No, within their normal cell, but just for long periods of time.
Right. You talk at paragraph 25. You say it was immediately clear to staff at Barnardo services in prison that a new response would be required. Is that need for a new response reflective of what the evidence you've already given? Yes? Yes.
Within lockdown, Barnardo staff weren't allowed in the prison. So we immediately made sure people had phones and videos, and once the process was in place, they were able to engage with young people through phones and video calls until the lockdown restrictions were further lifted and we could return.
And at 26, the first sentence of that is almost all people in prison were in shock. Now, is that COVID related, or is that just in general?
I think that's, people going into prison, obviously it is a shock to be there, but I think specifically for this context, it was COVID related. I think the whole of society was in a bit of a shock, if I'm honest. But on top of that, you're going into a prison environment, and people didn't know what to expect. And they were, also dealing with the impact of COVID.
And you talk in the same paragraph about dealing with people who had been in prison on a number of previous occasions. Did they find it easier?
They found it harder, actually. The reference there is to a woman who had been in and out of prison for various short sentences, and her comment on release was it was the hardest sentence that she'd ever had, that she found the long periods of isolation really distressing, impacted on her mental health and well-being, and she would much rather have had social contact with other people in prison. Some of the activities I've described earlier, one-to-one therapeutic support or group work, and that actually it was for her quite a tough sentence because of the amount of time that she was on her own during that particular sentence.
Okay, at 27, you say you increased direct support to families from our own charitable resources. Tell me about that. What were you doing in terms of support?
Yeah, I mean, Barnardo's has access to its own funds, and in addition, ourselves and Action for Children approached the Scottish Government and asked for additional financial assistance, which was released over a period of 3 or 4 different options. Over £1 million was released to charities to support families that needed immediate assistance. So that then enabled us to provide phones, laptops, food, activity packs for children and various other things to make the process of lockdown more bearable for them.
Was this, sorry, on you go. Was this support being provided to families on the outside or to prisoners on the inside?
Both, actually. So I think particularly when prisoners came in, they didn't often have the kind of things that they would normally have had. The impact of poverty during COVID meant that folk were really coming in mostly in the clothes that they were wearing, whereas pre-COVID they might have been a bit more prepared and had a bag with various things with them. So we provided support around toiletries, basics for people in prison. Similarly, on the release, the third sector provided release packs that included essential items, a phone with data, and it had loaded phone numbers and web addresses and that sort of thing in it. But we also reached out to families who had people in prison close to them and offered practical assistance to them as well.
In what way?
So emotional assistance, being on the end of the phone or a video to hear how they're getting on, and provide advice and guidance around that. When it was possible, we would take children and young people out of the family environment to have recreational and other opportunities, phones, laptops, food packages, activity packs for children, and general support to enable them to get through the period of lockdown, and at times to provide a communication process between the family on the outside and the person who was in prison.
Paragraph 30, I'd like to ask you about that in a little bit of detail. You talk about at the point at which Barnardo's staff could re-enter prison. You say, insofar as possible, you went back to what you'd been doing before.
Yeah, we would go back in, and as far as possible, we resumed our previous activities.
Yes.
So one-to-one therapeutic work, group work, and general supports and activities for the young people in prison. For a period of time, as I've described, that was within the bubbles. So Barnardo's staff might be part of a bubble of 4 to 6 people to enable those supports to be provided. And as the restrictions were lifted, we would resume normal activities.
Paragraph 30, you talk about Barnardo's filling a gap, effectively. Can you tell us about that?
It was really where I think the focus for the prison service, health service and statutory agencies were obviously the safety and well-being of people in prison, whereas the third sector and Barnardo's are able to go beyond that and think about mental health and well-being, emotional support, relationship building, enabling them to have meaningful contact with people who are close to them, and those kind of things, prepare for release, build essential skills to enable that release to be likely to be more positive in terms of outcomes for them, and do that sort of work. So I think that's the added value that Barnardo's and other people provided at that time.
In normal times, there will, I think, be a number of agencies involved in providing support for people transitioning from custody to life on the outside. In general, are Barnardo's involved in that?
Yes, but Barnardo's are involved through the services I mentioned earlier. Specifically, we're part of a public social partnership as well, which is Shine Women's Mentoring, which provides support to women at risk of custody and women coming out of custody. We've been a partner in that initiative for over 11 years now.
Well, tell us about Shine, because you made reference to that.
Shine Women's Mentoring, as I say, for women coming out of prison, can provide support for up to, sometimes beyond, 6 months. So pre-COVID, we would have had gate pickups. We would have gone and, staff would have gone and picked the women up from prison, taken them to where they're from, ensured that they attended essential appointments with homelessness, health, picked up prescriptions, met their children if they had care of their children, that sort of thing. Obviously, during COVID, gate pickups weren't possible, but we would meet people at the other end of their train journey and do some of that, and provide emotional and practical assistance, as well as programmes to prevent women from reoffending in the community.
Now, you talk at paragraph 32 about HM Prison Edinburgh stopping visits. But you had staff who were working in the visitor centre and providing assistance. What did they do? Were they furloughed?
No, they weren't. We didn't furlough. As far as I can recall, I don't think we furloughed very many direct children's services staff in Scotland, so they continued to work, and they were provided with phones and videos, and where they couldn't have face-to-face contact with families, they reached out through phone and video contact. When restrictions began to lift a bit, they would do things like drop off food and activity packs, as well as having kind of wellbeing check-ins with families to make sure everything was okay with the family and the children. I think it's referred to later on. Sometimes those wellbeing visits were also a safeguard to make sure that children were in appropriate living circumstances, etc. And with time, we were able to open up the visitor centre again and provide more activities for families themselves.
You say that SP, in paragraph 34, SPS gave us literature and leaflets and supported us with delivering food parcels. What did they do? How did they support you?
Yeah, no, they gave quite clear child-friendly, young people-friendly information about how they could keep in touch with their loved one, even if they couldn't visit, through things like video contact or writing letters, email a prisoner, those sorts of things. And they also supported in helping us put together food parcels that were then delivered to families.
By you, as an organisation?
Yeah. Yes.
No, I was wondering whether or not SPS were doing some of the deliveries.
And they were certainly supporting the welfare of families in different ways.
And then you talk about providing essentially financial support at 36 to families.
Yes. As I say, Barnardo's had its own funds, but also in total there was £1.3 million made available through a range of funds from the Scottish Government to children's services organisations, where we could disperse money for essential things during lockdown and during the COVID period.
And at 37 you talk about your involvement with virtual visits again. Can you tell us a bit more about that? Yeah,
the visitor centre provided 68 families with tablets, iPads or laptops to enable virtual visits. I think at its height across COVID, Barnardo Scotland were probably providing dozens, if not hundreds, of laptops and iPads to families to enable, engagement with services, including prison. And where it was needed, community-based staff would go to the family's home and help them set up the virtual visit, because some of our families are not at all familiar with using laptops or iPads or that way of engaging, and they would support children and young people through the virtual visit to enable them to have communication with the person in prison.
I thought every 12-year-old knew how to work an iPad.
Some of our young people are a bit disengaged from that part of life.
Okay. But, you talk at 39 of lockdown had a detrimental impact on people in prison. and presumably also family. You say that services were stretched in responding to the pandemic. Were prisoners prioritised, prisoners and their families?
Yeah, they were prioritised by the services that were involved with them, yes, I would say, yes, they were.
Right. Although you say at paragraph 40, connections with family and community support were difficult and less frequent.
Yeah, I think on the whole that was about the restrictions, the limitations, the stretch around staff shortages, staff being in lockdown, being unwell, suffering bereavement, having caring responsibilities for children, elderly relatives or people in nursing homes, etc. So I think the whole system was stretched in a way that we all experienced, and for families impacted by justice and with relatives in prison, that did make it additionally difficult.
In paragraph 40, you make specific reference to early release. Do you think that as an organisation, do you think that early release was used as effectively as it could have been?
We've been in support of early release mechanisms even prior to COVID, but ourselves and other organisations really pushed for those to be increased during the COVID period. I think it's fair to say they weren't used as frequently as we expected they would be during COVID.
And do you know why that was?
I'm not entirely sure. I mean, really the assessment is a governor's assessment of whether someone can be released or not. So what would happen is ourselves or other interested parties would make an application to the governor. Sometimes that was accepted and sometimes it wasn't.
Were you given reasons for?
You do get, we don't always get the feedback directly, but the governor does report the reasons for not allowing early release. That's available to SPS and is part of the monitoring process for early release, although we might not specifically be told that reason, it is available.
At 42, you talk about a variety of funding sources that became available during lockdown.
Yeah, that's right. The Immediate Priorities Fund was available from March to June 2020. Winter support funds, both winters of 2020-21, and the Get Into Summer Fund in 2021, which was around outdoor activities for families.
And were Barnardo's able to link in to each of those funds?
Yes, specifically we were allocated an amount of money that we were able to make use of or distribute through those funds.
Towards the end of your statement at paragraph 43, you talk about the pandemic and the response to it, showing the possibilities for various agencies to work together. Did that work well, in your view, during the pandemic? Yes,
it worked very well. I have to say the partnership arrangements were amazing at times during the COVID period, especially in lockdown. Obviously, all third sector agencies, including Barnardo's, are part of multi-agency groups across the country. Specifically, I work in Forth Valley and in Ayrshire, and quite quickly those multi-agency groups were galvanised and brought together to plan in relation to COVID. And some of the, I suppose, the traditional kind of restrictions around who does what were relaxed to enable us all to work effectively together to get the help that was needed to the people that needed it as quickly as possible. It was really refreshing to see that happening. It was an amazing collaborative effort.
And since the end of the lockdowns, has that continued?
It has continued. I would say the relationships have been strengthened as a result of that period. In some ways, we've maybe gone back to some of our traditional silos, but where it's possible, there is an intent for people to work collaboratively and not put restrictions in the place of getting help to people that need it.
Those are all the questions I have for you, but as has become traditional, we will ask, is there anything that you want to say that hasn't been covered in the statements that you've already made?
I think just one comment. We do tend to focus on quite a lot of the problems around lockdown COVID, But actually what I've seen is the resourcefulness and resilience of some individuals, some of the individuals within prison, and on the release from prison. I was actually amazed at how they coped and how much they were able to kind of just manage the situation, to the extent that some of them offered help and became volunteers, became employed, undertook training, and have subsequently been able to contribute in much more meaningful ways, I think, to society than they did before the pre-COVID period, and haven't returned to a life of offending. And I think it's really good to have those examples, as well as some of the limitations and restrictions and impact of the COVID period.
Thank you very much, Ms Bennett. No, nothing else for you.
Yes, thank you, Ms Bennett. Can I just say, in respect to that last remark you made when you were asked if you had any further comments, although obviously it's particularised to the prison sector and prisoners, the generality of it, that is that there are groups of people, some people, who responded very well, were resilient and adapted, is something that I think, particularly in the evidence that we've heard this past week from third sector organisations, is echoed, or you're echoing what they've said already. So.
Yeah, absolutely. I would say across the board within Barnardo's, volunteers, staff, people who are linked with us, funders, all sort of stepped up.
Yeah,
and
that's words that's been used again as well.
Yeah, vulnerable individuals, people who used their services, families under stress. Quite a lot of them did their best in very difficult circumstances, I would say.
Thank you. Very good.
Thank you very much.
Good. Now, we're obviously well ahead of schedule.
Yes.
I have no
Thank you.
idea whether the next witness is... Oh, she's here. I'm getting thumbs up. So it looks as if we might be able to come back rather than at 2:45, at 2:15 or just after 2:15.
Just after 2:15.
Just after 2:15 then. Good. That's very good. Thank you very much indeed. afternoon again, Mr. Caskey. Mr. Dickenson.
My lord.
Very good, thank you. On you go.
Thank you. Would you tell the inquiry your full name, please?
Yes, it's Vivian Dickenson.
And in what capacity are you here today?
I'm here as the Chief Executive Officer of Crossreach, which is the social care arm for the Church of Scotland.
And how long have you worked for that organisation?
I've worked for the organisation for over 20 years in a variety of different roles and took up the role of Chief Executive in 2017.
You talk and you've provided us with a detailed and quite lengthy witness statement. That witness statement is reference SCI WT 0538501. That's simply for our records, as it were. Do you recall that statement?
Yes, I do.
And do you have it there in front of you?
Yes, I do.
Is the content of the statement true?
Yes, to the best of my knowledge, it's all true.
And do you wish to adopt that statement as part of your evidence to Lord Brailsford today?
Yes.
Okay. Lord Brailsford will proceed on the basis that everything within the witness statement has passed from your lips today, so it's not necessary for me to get you to repeat large parts of it, but there are some matters which I want to focus on. You talk at paragraph 6 of the Coalition of Care and Support Providers. Now, we've heard of that organisation from a number of people. Can you tell us your understanding of what it is and what your involvement is?
Yes, so it's a collaboration of third sector providers and who Coalition of Care Providers Scotland helps to organise the providers, give support and advice, and is a conduit of information between providers, government and sometimes local government.
And do you have a particular role within that organisation?
Yes, currently I'm on the board of the Coalition of Care and Support Providers in Scotland.
Now, as you will be aware, we have heard evidence, particularly this week, from a number of care providers, most of whom in the third sector have made reference to that organisation. But I want to ask you some questions about your own organisation. You tell me about the scale of the organisation. Give us an idea of how big you are.
Okay, so it is a large organisation and is fairly unusual in the diversity of services that it provides in the voluntary sector. So we work over 28 local authorities, or did at the time of COVID. We're roughly divided into 3 sections. We work with very young children and children up to the age of 18. Then we have adult care services from 18 to 65, and then older people's services roughly 65 plus. We work in children's services. We do counselling, prison visitor centres, we have looked after and accommodated children, we run our own school, we do early years work. In adult services, we have mental health, learning disability, criminal justice, substance use, and then we have residential care for older people and community support for people living with dementia. We've got about 1,700 staff and we trade to about £52 million a year.
So a fairly substantial organisation.
Fairly substantial.
And you provide details of that at paragraph 12 of your witness statement.
Yeah.
At paragraph 13, you talk about your geographic reach. Can you tell the inquiry about that?
Yes. As I've said, we work in about 28 of the local authority areas. So our furthest north service would be Walter and Joan Gray Care Home in Shetland, and our furthest south is a therapeutic arts group for people living with dementia in Galashiels, and kind of everything in between, really.
And tell me about your funding.
So while we're run under the auspices of the Church of Scotland, actually only a small amount of our funding comes from Church of Scotland. That's about 2%. About 67% of the funding comes directly through local authorities. Some of our funding comes from people paying for their own care directly through care homes, and much of the funding is brought in charitably.
Okay. Now, I understand that you've had the opportunity to watch on YouTube a number of the other witnesses who have provided evidence to Lord Brailsford. In terms of the witness statement you've provided, it would seem that a significant amount of the evidence that you tender to the tribunal overlaps with what we've heard from other people. Is that correct?
Yes, that's correct.
In particular, who do you think you overlap with?
Well, I heard some of the evidence from Dr McCaskill earlier this week, and then some of the providers of care homes. So there's some overlapping evidence there. I heard a bit of the Quarriers evidence, so there's some overlapping evidence there. A bit of Sally Ann Kelly's evidence, so we have an overlap there, and also a slight overlap with Nancy Loups, who was on earlier today as well.
I'm very impressed. It's very public spirited of you.
We all get paid to listen to it. One of the other things which you will have heard is that third sector organisations have prepared at an early stage and switched many of their non-residential services to online. Can you tell me, is that reflective of what Crossreach did?
Yes, so many of our services are residential services. They're 24 hours a day, 365 days a year. So it was impossible, in a sense, to turn these services online, other than to help people to connect with the outside world, to families and other support people who matter to them. So that activity went online. In most of the community services, initially telephone support was provided, or different types of support. So we would make packs up for the children that we support, either in prison visitor centres or children affected by substance use, to send out to them, so that to help with their mental health and well-being over that time. And then we would follow up initially by phone calls and eventually on virtual platforms. Our whole counselling provision, which was all face-to-face at one point, had to shut down initially. And then we were able, through the Scottish Government funding, to turn that whole provision online, but that involved training over 80 counsellors in online counselling, which is different to face-to-face counselling. And we did want to make sure that they were operating well and within their professional boundaries on that platform too. So our mental health support in the community, again, initially by telephone and then online as well. So it did mean a massive turning on its head of our traditional face-to-face support into online telephone support.
At paragraph 23, at paragraph 22, you talk about setting up basically a brains trust, if I can put it that way, of people who were providing advice to various managers as to how to deal with government guidance. Yes?
Yes.
And at 23, you say initially the guidance was very scattered. How did you cope with that?
I suppose how we coped was by having that central focus group who were taking in guidance from all sorts of places and trying to interpret that for the organisation. So, people were being helpful. Essentially, we were getting advice from public health. There might be stuff coming down from Care Inspectorate. There was certainly stuff coming down from government, local health protection teams. And what we were trying to do was to bring that in and make sense of it for an organisation which was operating in different geographical areas and a staff team who you know, had different functions within the organisation. So bringing in that contingency planning group, making sure that we were on top of all of the information coming in and that we could interpret it well and get it out to the right people at the right time became increasingly important.
Paragraph 25, you talk about a difficulty for cross-reach because it's a large and diverse organisation. Tell me about those difficulties.
But part of the difficulty, I think, is our own difficulty in being large and diverse. So you've got, sometimes things would come out on the news saying, well, there's a testing programme about to be implemented, for example. So all of our workforce would think, well, that's for all of us. And actually, when you get into the guidance, it's very clear that it's going to apply in care homes first and potentially not for other people initially. So that diversity, both in terms of the types of service that we run, but also geographically, eventually as tiers came in and that sort of thing, trying to interpret that for a diverse workforce doing lots of different types of work was incredibly difficult. We would work with that in a variety of ways, but I think it also highlights something about where government response didn't quite understand that diversity of social care. So what we would get, and the evidence that I've listened to, particularly from Scottish Care and Jean Freeman's evidence to the COVID inquiry, was lots about information coming down for care homes and care at home, and not a lot of thought being given to the huge diversity which exists within the sector, because while some care is delivered in care homes and care at home, lots of social care is delivered in people's homes, in community settings. And it is about helping people to live their life to the fullest possible through good, supportive and enabling relationships. And I think that that real focus on care homes and care at home initially stopped thinking about the broader implications of guidance on social care and that ability of people to live their lives to the full.
So is it your evidence that in terms of setting out guidance and so on, those who were establishing the guidance were focused on care homes primarily to the detriment of other care settings? Yes,
that was my initial view, and certainly that's where the bulk of the evidence, the bulk of the guidance initially came from.
Now, you were dealing with a wide variety of care environments. Can I take you to paragraph 28, which is something of a description of your organisation's response to that? You sent out 80 bulletins.
We did. And many local protocols. So this was us trying to support the organisation to understand the guidance, because people were busy. I cannot tell you how busy it got in the organisation with trying to continue to provide support to all of the people, 25,000 plus potentially, who are in receipt of care services in some way or other from us. So they don't have time to go through all of that guidance. They particularly don't have time to go through guidance that changes day to day. And there were a lot of questions coming up from staff about, keeping themselves safe, keeping other people safe, whether particular guidance applied to them. So the 80 bulletins was our attempt to bring that all together and get out the most important messages to managers so they didn't have to sift through it and could implement safely.
So guidance would go out, which might be applicable in a variety of sources, but your central team would break that down and say, John, this might be relevant to you.
Yes, care homes, care at home, community support settings, all staff, that type of thing. Yeah.
Why didn't the guidance do that itself?
I think it was, well, I'm not sure really. I guess there wasn't, as I said before, that kind of understanding of all of the settings in which social care is delivered, and potentially not an understanding, even in the care home sector, of how different care homes are. And you heard about that, I think, from Ron Cully yesterday. The largest care home we run is 40 beds for older people, but the smallest we run is for 3 bedrooms for people who actually live together, enjoy cooking a meal together, are companions. So, it needed a bit of flexibility and a bit of interpretation so that staff could implement in the best way possible for those that they support.
I'll come on to ask you about the care inspectorate and so on later, but you say it needed a degree of flexibility. Was that something that was reflected, for example, in the care inspectorate? Did they recognise the need for flexibility?
I think that as the scrutiny on care homes became more intense through the pandemic, and models of care were forced down a much more clinical pathway, that degree of flexibility was difficult to achieve.
Tell me about the clinical pathway. What do you mean by that?
So, the guidance that particularly came out for care homes, and remember we're talking
for care homes, yeah.
For care homes. If we just talk about care homes specifically for the moment, I think there was a sense that we could turn these into mini hospitals. So I've referred in my evidence to the cleaning regimes that were adopted, the fact that residents own rooms. We were asked to put away things that were important to them, books, potentially magazines, photographs that maybe weren't in frames, that type of thing that couldn't be wiped down and cleaned, but actually might mean a lot to that resident. And where there was an outbreak, I think at one point it was suggested that we move the infected residents into one part of the building and non-infected residents into another.
So how that doesn't fit with the model you described a moment ago of my room in my care home being my home?
That's it. So there was quite a lot of work needing to be done to say either we can't implement that or we have to be more flexible in our implementation of that particular piece of guidance. And if I'm thinking about older people with dementia, particularly those who find it important to walk, that actually that's what they do. They move. They sometimes move because it's comforting, and sometimes they're moving to find other people or to congregate in the places that are familiar. Actually, to ask them to isolate made no sense whatsoever. That it doesn't become self-isolation then. There's not a choice in that. It becomes imposed isolation. And it was that type of conversation initially. We're going, how does this apply? And we are going to have to be more flexible, because short of locking people in the rooms, there were times where we couldn't have applied that guidance.
I took you to paragraph 33 deliberately before I'm taking you to paragraph 32. Tell us about paragraph 32. Your information tracker.
So the information tracker, again, this was us trying to keep track of information as it came into the organisation so that we would have a record. So if information changed from one day to another, and significant changes we're talking about here, that actually we would capture it so that it wasn't lost to us, and we could go back and say, well, actually, did we implement that before we move on to the next thing, or potentially have we implemented all 3 things that came in that day? And it would just allow us to make sure that we were getting information out to the right people at the right time.
You talk about guidance changing on a daily basis, but obviously it didn't change every day. No. Was there a particular time during the week that new guidance would hit your inbox?
Oh yes, and I think that's been highlighted by a number of people that Friday afternoon syndrome, as we called it, was particularly difficult. And I understand that the guidance was going through a whole lot of people checking the robustness of that guidance, but actually to bring it out on a Friday afternoon was particularly difficult in organisations. So where people had been working really hard all week to implement either the guidance the week before or things that were coming out during the course of that week. So to put that in context, our contingency planning group were meeting first thing in the morning, at lunchtime, and then at 5 o'clock again in the evening, to make sure that we were capturing all of the information that had come out that day, particularly if they'd been on the lunchtime sessions, to make sure that we were on top of it for the next day.
Let me ask a development of that based on paragraph 33, if I may.
Yeah.
You give an example there of a bulletin, a guidance coming out in the morning. You're the appropriate person in your organisation writing a bulletin to deal with that, and then at 4 o'clock it's changed. So that's guidance changing in the course of hours.
Yes.
Was that a one-off, or did that happen more than once?
I think it happened more than once, but it was infrequent that it changed that quickly.
But it did happen.
It did happen.
And where short-term change is more common. You know, Lord Brailsford has asked you about kind of 9 o'clock in the morning to 4 o'clock in the afternoon, start again. Mm-hmm. But was there other guides that would come out that would need to be changed, perhaps not as quick, or which was changed, perhaps not as quickly as that, but still very quickly?
Yes, and it was a developing pandemic, and I guess there was information being received by government the whole time that they were reacting to. So, for example, I think there was a bulletin where we sent out something saying PPE only needs to be worn in a situation where there's an infection in a care home. By the next day that changed, and it had to be used as a protective measure whether or not there was COVID infection in the care home. So, you know, you're literally saying, right, okay, we sent that out yesterday, but by today we need you all to be wearing PPE as a preventative measure. So and you know, when you're trying to do your best for people and genuinely keep them safe and supported, you're taking that guidance very seriously. We're not trying to lose pace on what government are telling us is the best evidence. So that push to get information out becomes really important. But we probably really needed 2 days to implement well.
And was there an expectation? You talked about clinicalising care homes, and also that there was a failure to recognise the diversity of social care. How did that impact? I mean, were there situations where you were getting guidance in for which the author of the guidance clearly had in mind elderly care homes, but you recognised that you needed to deal with that for other types of care home for young people with addiction problems?
Yes. So what we would be doing is looking at the guidance, thinking this does apply in older people's care homes, but actually we've had very little out on residential care for children, for example. So what of this makes sense to apply in that setting? Because once you know something, you have to think, well, actually, does it make sense to apply it elsewhere? And also, the guidance says, staff should be able to wear PPE on a risk-assessed basis. Now, I think that guidance was largely coming out for care homes, but when you've got an organisation such as ours, you're trying not to discriminate between your staff, because they're essentially doing similar tasks. They're supporting people very closely with personal care in some instances. Not everybody needs that, but if you are in a number of settings, then you're trying to make sure that actually you are giving all staff equal access to the resources that are going to protect them.
So you talk about having your thrice daily meetings. You also talk about the Coalition of Care and Support Providers having meetings on Monday morning, and you were receiving information from public health advice from a variety of sources throughout the day. How was that manageable?
It took a very concerted effort to unpick the guidance, and then it would be highlighted to me where people were saying, we don't understand this, we don't know how that can be implemented, and I would be back in touch with Care Support Provider Scotland, and often it was a sector-wide issue that they would then agree to take forward. And sometimes I was just, talking to government officials directly about a particular piece of guidance. Isolation for staff or staff benefits. When the staff first had to isolate, what were we doing to support them? It's going to be really difficult to apply this piece of guidance if nothing's coming down to support the sector to allow them to do that. So it's that type of conversation that we were kind of having the whole time. But as things changed, the role of both Scottish Care, I have to say, and the Coalition of Care Providers Scotland, when they organised into the meetings and there was that conduit of information going back and forward, it was incredibly helpful to the sector.
Were Scottish Government involved in that? Was the Care Inspectorate involved in that? Were the other statutory organisations involved in what was clearly an important information dissemination process? Did they become involved?
At that higher level, so our job really at that point was trying to make sense of information, to raise it with the sector representatives and for them to raise it then with the appropriate authorities. So that might be government, it might be Care Inspectorate, it might be public health. And really that's where these conversations were happening. We might, on a local level, be talking to a health protection team or a social worker or a local authority about how they were applying a piece of guidance in that particular area. But the kind of bigger issues that needed that top-level strategic support were basically being run through Scottish Care and Coalition of Care Providers Scotland so that we had some consistency across the sector.
And so all of these things were feeding in.
Yes.
And that takes me back to your information tracker. Was the information tracker gathering all of this stuff for all of this material for your staff and others?
Yes. So so the big change is we were gathering on that information tracker. An awful lot of the rest of it is in minutes of the contingency planning group, or that type of thing. Actually, as decisions were taken or issues were raised, we actually had a tracker that was saying things that have gone from our contingency planning group into the national contingency planning group, that type of thing, so that we could make sure that we were actually getting answers and feeding them back. Because things were changing so quickly, sometimes it was difficult to keep track of a question you'd asked the day before and make sure you were getting an answer, because it remained important as things were changing as well.
I do mean this flippantly. Right? Was there steam coming out of the thing? Was it just being updated all the time?
Yeah, it was complicated, and it was complicated for all of us. I get that, and I know that government officials that I dealt with were working incredibly hard to respond to the many queries that the sector were putting up as well. But yes, on some days, it did feel overwhelming.
Okay. You move on in your witness statement at paragraph 41 to start to talk about care homes. And unusually, could I ask you to tell us about paragraph 41, which is really about the philosophy that Crossreach has in relation to its care homes?
Yes, so we run residential care homes. They're not nursing care homes, or they're not nursing homes. And our philosophy is that if you need the support of a care home, it's because you've reached a particular point of frailty, either in your physical or cognitive well-being, that demands that type of support. But that doesn't mean that you should give up the right to live as full a life as possible in an environment that feels as much at home as possible. And that's really our philosophy, that we try to make this, you've given up your home, you're coming into our home, but we want this to be your home, and we want you to be able to live your life as fully as possible within that environment.
You referred earlier to the possibility of moving people from their home into a different home within the same building, but having what in a hospital would be called a red corridor and a green corridor in terms of COVID infection. How did that sit with your organisation's philosophy about care homes?
We couldn't apply that. As far as we're concerned, the residence room and all of the communal areas are their home, and to move them, particularly at a time when there was so much other disruption happening, just wasn't possible, and wouldn't have been reasonable, in my view, wouldn't have been proportionate. So, so as you're moving potentially from one ward to another, you can't do that in a care home.
And I think you give the example in your witness statement about there not being a move to set up ghettos for the COVID infected in society generally.
That's right. Yes. So why would you do that in a care home environment? And now that, I mean, I think we refuted that quite quickly, and actually it was, the common sense of it was seen, but nevertheless I think the initial expectation or thought was that we could organise in that way.
At 44, you talk about the percentage of residents in your care home suffering from dementia and the particular difficulty that gave rise to. Can you just tell us about paragraph 44?
Yes, so I would say between 80 and 82% of residents in our care home are living with dementia, either diagnosed or undiagnosed. So we do have a number of dementia specialist care homes, but even in our general care homes, there are many people living with dementia. And they're very dependent on consistency of routine, of caring staff, of their visitors coming in, their loved ones, the prompts that they have in their rooms, the things that they have round about. And it was very difficult in a situation where guidance was asking us to change things, to explain the necessity for that, for them to understand that, and to, particularly when a care home was COVID positive, to be able to abide by the rules that were coming down. And in fact, they needed some familiarity in order not to become more stressed and distressed, I guess, in that situation.
Paragraph 45, your evidence is reflective of other evidence we've heard about the impact of the isolation policy on those with dementia. Do you want to say anything that we haven't already heard about that?
I think the case has been made very well that isolation for a particular group of residents in care homes was incredibly difficult.
And then could you read paragraph 46, please?
Okay, first you saw a curtailment of visiting, then of communal activity, and then an introduction of cleanliness and sterility, which disrupts the very nature of home and feels more like a clinical environment. So there was a huge risk of people becoming more and more isolated as time went on. In addition to that, and while expecting staff to follow clinical standards, there was an initial failure to provide the resources we needed to respond to the instructions coming down, it felt like we were a second-class sector.
And at 47, you indicate that mental health issues or distress behaviour due to increased isolation.
Yes. We saw that in a number of settings, I guess, but as we're focusing on care homes at the moment, that isolation for people with dementia and the lack of availability of family to support that initially was incredibly difficult. And I said at the end of that there, while people were maybe being protected there, I think there's a balance of risks here, and I would say that many residents were not living life to the full during that time now. A lot of society wasn't living life to the full, but certainly for our residents, I think they were living in a very sterile environment at times, and some would die in these circumstances.
You move on to discuss PPE next. Can I take you to paragraph 51 and just ask you to read that over and remind yourself, and then tell Lord Brailsford about that?
Yeah, so this is the piece of guidance where it was clear that this was an airborne infection, and it was clear that one of the routes to supporting safety was use of PPE. The staff were, so I think probably in response to the questions we were asking, the piece of guidance came down that said staff should be able to wear PPE on a risk-assessed basis. Now, in some situations that's quite helpful, so in children's houses, for example, it would be quite traumatising to see staff going around in PPE the whole time. So that risk-assessed basis and flexibility did have some use some of the time. But the trouble is, if you've got a very highly anxious staff group and you've got some staff wearing PPE in some situations and others that don't have availability are doing that, and then suddenly think, actually, I can wear this on a risk-assessed basis, they're wearing it, I want to wear it, and you don't have the supply, you're kind of making things worse. You're kind of upping the ante, I think, on anxiety, and that was difficult. We remember writing that into the bulletin and a big debate in that contingency planning group about, actually, can we really write that into the bulletin? I know it's the guidance coming down, but actually this isn't particularly going to help the staff group. So we then made it our mission to make sure that we had adequate PPE wherever possible, and we went out very hard on both procuring PPE and distributing it to the 52 environments which were still operating at that time.
You talk about one piece of guidance which indicated that individual staff members should carry out their own risk assessment. My question is this: would your risk assessment be the same as mine?
It may well not be, yes.
There's then, you move on to restrictions on visiting, and we heard a lot, particularly before Christmas, about restrictions on visiting. We heard about the difficulties with window visits and the impact of those in care suffering from dementia and how they couldn't understand, particularly if their health was declining. Is there anything that you want to add to those bold headlines? I think this was possibly one of the most difficult policies for us throughout the pandemic. We were very clear that we would allow essential visits from the start, so we did that as an organisation, and we didn't. So yours weren't any of the care homes that said no essential visits?
No, we allowed essential visits throughout, and actually that I was reminded about that as I was reading through the bulletins right from the start. It was visiting is going to be curtailed, but essential visits must be allowed in all cases. But as time went on, I think this just became more and more difficult for managers to manage, because we had distressed residents, we had distressed visitors, we had public health teams giving advice and government giving advice. And again, I think in the initial stages wasn't enough flexibility given to managers to be able to potentially, if we could manage essential visits safely, we could have managed other visits safely.
For the managers, you ultimately are their boss.
Yes.
No one would go outside government guidance. Why is that?
Because public health guidance has the backing of the law behind it. Also, as the pandemic progressed, and I think I've referred to this in other places in the statement, all care home deaths then became examined by the Procurator Fiscal. So you had that nervousness in the sector. If we do something to compromise the infection coming in, then potentially we're going to be found at fault. So you're worried about that. You've got guidance with public health guidance with the backing of the law behind it. You've actually got the Procurator Fiscal looking at every death that's happening as a result of COVID, or even every suspected death, because people weren't coming in to certify COVID deaths. Some of these were suspected deaths. And then eventually you had the insurers saying, we're not going to insure in these circumstances either. So you've got a kind of triple whammy there, which is making it very difficult not to take a risk-averse approach to visiting in these circumstances, despite the very obvious distress that we were seeing. And I think that was really tricky.
And at 58, you make reference to the difficulty in accessing medical care for those in your care homes. GPs and nurses just refuse to come in.
Yes. In some areas were better than others, but on the whole, getting care for residents in a care home at that time was incredibly difficult. And I think medical care, and I think that you've heard that from other providers as well.
And in terms of transfers from care homes to hospitals, was that difficult?
Yes, and again, different areas of the country behaved differently, but I did have to intervene quite strongly on behalf of one resident who had fallen with a suspected cracked hip, and the health board, I won't name the health board, were refusing to admit to hospital or send an ambulance at that point. And we raised that very quickly and actually got a response fairly quickly, and the resident was then moved to hospital. And I have to say that was contrary to government advice at the time. The government advice was clear, and Jean Freeman, I think, put out a very clear directive saying that care home residents should be supported with our clinical needs in the same way as anybody else in the country.
You talk about intervening personally in your professional capacity in 2 cases at paragraph 60.
Yes. Yes, that's right. And that's where the care home manager had done everything they could. Their director had probably done everything they could. So eventually it's for me to raise at a very senior strategic level to say, here's the directive, here's an example where it's not happening. We have someone who is in need of care, and something needs to move.
And it did.
And it did.
62, you talk about discriminatory practice. Tell us about that.
I think there was discriminatory practice because I think care homes were put that older people had a particularly hard time if they were living in a care home during this pandemic. That movement of people from hospitals into care homes was tricky. Deprioritising resources to care homes. I mean, we felt that a lot of the effort was going into hospital, that residents couldn't get the care that they needed, that they were increasingly isolated from family and friends. All of that sort of thing, I think, didn't uphold their human rights, and potentially there was discrimination in the way that that care home population were treated.
Paragraph 64, you talk about the reverse of that, and that's people going from hospital to care homes. You took a firm line in relation to that.
We did. We took a pretty firm line early on. Early on we were protected because we had high occupancy, so when the first call came to empty from hospital into care homes, actually we were very limited in our capacity to be able to do so.
What was your occupation rate at that stage?
At that stage, 94%. So it was high. We were very cautious, even from the very start, and didn't have a lot of space, so we were able to rebut some of the requests coming through until we'd thought about on what basis would we admit, and we made testing the basis of admission.
At paragraph 66, you say that and give your view.
Yes, in my view, it was ill-advised to discharge people from hospital into care homes from COVID positive wards at the beginning of the pandemic.
Okay. Sorry, sir.
No, I was nodding.
At paragraph 67,
agreement, actually.
you make reference, as you did a few moments ago, to Operation Copper. From your evidence a few moments ago, it may be that the impression could be gained that you think it had a chilling effect. Would that be fair?
It has certainly affected the mental health of many of my managers, I would say, and I think has had
Sorry, do you mean that seriously?
I mean that seriously.
Right, so it's not just they were a bit upset about it?
No, it has played in their minds significantly, because they did all they could to obey the guidance, to do what we asked them to. Many of them went over and above what we could reasonably expect. For example, staying over in care homes in order to protect residents and their own families.
So that's care home managers effectively moving into the care home?
Yeah, in some cases. With having agreed that by public health, but particularly where isolation policies came in, and that actually if you had numbers of staff isolating, the managers just preferred to be on site so that they could they could be the helping hands in that situation. Operation Copper has been difficult because it has been applied so widely. So it's not that anybody who has not applied the guidance, not tried their best, where there has been negligence, shouldn't be looked at. Of course that should be looked at, and anyone who's lost a member of a family has a right to be asking questions in that situation. But 4 years on, all of these deaths are still open to scrutiny, and there's no suggestion that we have done anything wrong. So I've had conversation with the Procurator Fiscal about at what point some of these cases will be closed, and we still don't have a resolution to that. It just feels that it's disproportionate, particularly when more deaths occurred in hospital. And I'm not suggesting the NHS are held to that level of scrutiny. They did a fabulous job. And I'm not suggesting that in the least. It just feels disproportionate in the way that this has been applied to care homes. And you can understand that if you're a manager and you're waiting to hear whether a particular death or a number of deaths in your care home have been due to your negligence, or that could be alleged, that can put you under severe strain. And some managers have chosen to leave the sector because that level of uncertainty and scrutiny has become unbearable for them.
That evidence you've just given matches well now word for word to something we've heard before on at least one other occasion.
Yes.
I think I should say that there's not a great deal we can do taking this much further on the basis that this is a matter which is currently under investigation by the prosecuting authorities, and we hear what you say, we note it, but we can't do much more about that until such time as the Procurator Fiscal, the Lord Advocate, has made determinations in relation to these cases. Yeah. So it's not an apology. No. I'm just stating to you, I'm sure you understand that.
I do understand
the factual circumstances in which we are operating.
Yes, but this is an inquiry into how COVID has affected our organisation and the sector, and I'm giving an honest account of that. I do completely understand that the Procurator Fiscal is independent and will take its own view on when it feels it's done enough to close some of these cases.
Yeah. Thank you.
We'll talk about another a quasi-independent organisation now, and that's your insurers, paragraphs 69 and 70. They're independent in the sense that they can pull the plug if they want to. Tell me about that.
So that was a scary moment. So October 2020, we're coming up to renewal, and insurers, I think at that point, were taking a view about the risk of the social care sector in general, and you've got Procurator Fiscal inquiries, but you've also got the potential of claims coming through, and we had some fairly in-depth conversations with the insurers about how we were managing and mitigating risks, giving them access to our information tracker, to the bulletins, all of that sort of thing, in order to reassure them that we were doing everything possible. But it was more or less universal at that point that infectious disease cover was removed as organisations were coming up to the renewal, and so it was for us. So we were then operating at risk after October 2020 in terms of had somebody wanted to bring a claim against us.
You had help from higher up though.
We did. So at that point, I pointed out the risk to our charity, which is the trustees of the Church of Scotland, and asked if they would agree to insuring us so that we could continue with some certainty as an organisation, and they agreed to do that.
I didn't mean higher up.
Yeah. I think there's a particular, and this might have been discussed with you already, a particular provision in Scottish law, and I can understand the insurers taking a bit of fright in that, and it's something called Loss of Society Awards. So whereas in England, I've got the email from the broker saying, something might settle in England for 20,000 in Scotland because all family members can make a claim, or then actually this loss of society means that they, rather than settling with one person, you could be settling with 12, and that opens up the risk to insurers. And you can see that actually that became worrying for them.
Can I just go back one answer? Yes. Because of the difficulties with insurance, which I understand totally, you went to the Church of Scotland, who are effectively, you explained the constitutional relationship between you and the Church of Scotland, but the Church of Scotland effectively agreed, from what you've just told me, to cover you. Yeah. So that effectively means, and this is possibly important for us, that effectively means that you became reliant on self-insurance.
Yes. Yeah. That's it.
Yeah. Which is not unknown in the insurance world. Some very large organisations choose for many reasons to be self-insured, but it's quite unusual.
It is quite unusual.
And again, with no disrespect intended, for an organisation, I think, if my memory serves me correctly, you told me that your budget or your turnover was in the order of £32 million a year. I think my experience tells me it'd be most unusual for an organisation of that relative smallness to be self-insured for anything, to be perfectly blunt.
Yes, it wasn't a good moment. It was one of those that will stay with me.
No, but we can note that you effectively. What date was that?
It was October 2020.
So from October 2020, and did that go on until when?
I think till about 2022, as I remember it, when insurance companies opened up the opportunity to renegotiate on infectious diseases cover. So from October.
We haven't asked anyone else about this so far, but so from October 2020 until 2022, you were unable to obtain insurance cover for infectious disease risk, and you were fortunate that your overriding body provided you with cover, which meant that you were self-insuring.
Yeah.
But I think we heard similar evidence from someone at a care home in Skye.
Well, we may investigate this, or we may ask questions further, because obviously it's quite important if care homes were requiring, if they were going to go on operating, to be self-insured for infectious disease risk.
Yes, and we did raise it on a number of occasions with government, and I know that Dr McCaskill raised it on our behalf, as did CCPS, that actually they were indemnifying NHS. We're providing something on behalf of the statutory sector. Older people have a right to care, and would they indemnify us over that period? But they couldn't find a way of doing that.
No. I wonder, Ms Caskey, if you could make a note and have the solicitors look into that, see if we've got any other evidence and any statements about that, and we can follow that up. Thank you.
I'm looking at paragraph 73 now, and you talk there about the changing behaviour of the care inspectorate. Yeah. Tell me about that.
Yes, so prior to the pandemic, we're very used to care inspectorate visits, which are based on the health and social care standards, but which are primarily making sure that we're providing the environment and the staffing to be able to deliver good outcomes for people. That's our purpose, and that they would come in just to make sure that we were doing everything possible in terms of training, management and leadership, all of the rest of it, to make sure that that good outcomes for people were being met. During the course of the pandemic, that felt like it changed. Initially, care inspectorate weren't doing inspections, not coming in to do them, and then at some point the inspections had much more of a health focus, in my opinion, rather than an outcomes focus. So actually what you were being judged on was the cleanliness of the environment and the way that you were applying the infection and prevention control standards, rather than necessarily good outcomes for people. And that was tricky. That's a tricky thing.
Give a particular example in your statement, as I recall it, in relation to handrail.
Yes, the care inspectorate had to behave in this way, because actually I think it was an amendment in coronavirus legislation that asked the care inspectorate to go in, inspect on a number of issues, and then bring the results of these inspections to Scottish Government. So I do understand that actually this was under the legislation, but we had a situation in one of our care homes where they'd come in, and we have wooden handrails, old care homes, many in old buildings, and we've been using exactly as was specified in terms of the fluid, but it rubbed away the surface. That's what happens, when you use corrosive fluids basically on polished wooden handrails. And I think in one of the toilets, they felt that there should be an additional soap dispenser or a soap dispenser of a particular standard. And they asked the manager to rectify that. They said they'd be back to make sure that that was all happening. Now, the manager takes that very seriously and does all that they can to, one, in a pandemic situation, to track down a supplier that will supply exactly what is required there, and then to find a contractor to fit them. And they couldn't do that within 3 days. But they had a plan of work in place to do that, and that was shown to the care inspector at that time, but it was judged as a requirement that hadn't been met, and contributed to that care home being marked down, and then that being laid before a Parliament as inadequate. And I think that fails to take into account the operating context in a global pandemic, that actually both supplies of goods and services and getting contractors in a safe way, because you're risk assessing your contractors coming in as well, to do pieces of work just wasn't really properly taken into consideration.
And was that repair work that was being required time limited? Were you told do it?
Yeah, 3 days.
3 days?
Yeah.
So you had to find and engage and have in a supplier within 3 days during lockdown. Yeah. The next section is in your statement is headed Rural Scotland. You've explained there difficulties in getting materials, particularly PPE, up to Shetland, although Shetland basically did their own thing, as is often the way in Shetland, and the same in Lewis, where you also were involved. Is there anything that you need to say in terms of, apart from the blatantly obvious about transport difficulties and communication difficulties generally?
No, we did our best to support our rural establishments in the same way that we supported other establishments, but rurality does make that difference. The manager, or the person who was deputy manager at the time, is now the manager of that care home, has agreed to make a statement to the inquiry, and that I think will give you more evidence about how the rural care homes were managing in that particular circumstance.
I don't want to pry, but I understand that's quite unusual for a care home manager to be willing to give us a statement.
Yeah, well, yes.
From your organisation?
From our organisation. What we've been doing our best is to people who wanted to make a statement and have been doing so under Let's Be Heard, but we have not wanted to put managers who are already significantly stressed and who have worked through the pandemic through that situation. However, because of the interest in rural care homes, this particular manager has agreed to make that statement, and we've supported that.
But for the others who are less inclined to do so, is that reflective of what I described as the chilling effect of Operation Copper?
That's right, yeah. They wouldn't want to be compromised.
No. I note that the next sections, and it might be possible to take these two together, in your witness statement relate to homelessness and mental health support, and often those things run together. Can you take me through that?
We are running short of time.
Yes.
So I apologise, but we do have to keep to timetables, in fairness. But do your best, Mr. Caskey.
I'll do what I can, my lord. Yes. Is there anything that's not in the statement that you could usefully add to what's there?
No, I think the statement, all I've done, I could go on in each of these services for quite some length. What I've done is just actually taken a few examples of how services were affected, and can give you more information if that's required. And
presumably you would do the same with learning disabilities, although there is one example, I think, there about you provide an example of a child who had a condition, or was that in the next section, looked after children who had an eating?
Yes, so that's an adult with a particular compulsive behaviour, an unusual one, where actually they eat things that they shouldn't or that aren't good for them. And in this particular setting, again, it's about guidance coming down and very little flexibility being applied in a setting. So in order to keep that person safe, we have a locked bin in the environment in which they live in. But it's not the standard infection protection control bin. And so, again, when the care inspectorate came in on assurance visits during the pandemic, they insisted that the bin was changed. Now, that might have made sense in terms of infection protection control, but in my view was replacing the potential of one harm with another. And I actually think that could have been managed perfectly well with the bin that was in place, and potentially an additional clinical bin elsewhere. But it is that constant balance and the need for flexibility when those closest to others and in a relationship with them can work out how best to help them to live life well. And yet something's getting in the way of that. We need managers to be able to say, actually, I'm not accepting that, and in this situation, I need to do what's best for the outcome for this particular person.
You move on to drug addiction services and rehabilitation. Could I just ask you to read the beginning of 134 aloud, and then ask you to say something about it?
Yes, a blanket approach was taken in respect of drug addiction services and rehabilitation. Again, one of the big questions at the beginning was around the classification of a residential rehabilitation service and how guidance could be applied.
Do you have anything to say in relation to that? No. Nothing new. You move on then to talk about financial impact, and we've heard quite a lot about that. 147, your occupancy went down from 94 to 70% over the course of the pandemic, and you explained why that is, that whilst people were dying, other people were unwilling to go into care homes. Yes. Because people were dying.
Yes. Yes, that's right. And because you couldn't visit a loved one in a care home. I mean, that significantly affected people's decisions. So at that time, and also, I think because people potentially were not out at work, it was easier to make the decision to manage however difficult it was at home than to take the risk of some and not being able to see a loved one for some period of time.
Okay, this morning when I was examining a chief executive from another organisation, when we came to the part of the witness statement that said staff, I said, you're not going to be the first one who said my staff weren't very good. Everyone says their staff were excellent. Is there anything in particular, apart from staff went above and beyond, that you want to say there?
Other than, I think, and you have heard this before, the innovative practice, the ways, when some of the bureaucracy was removed, in terms of funding coming down, I think people were saying, just do your best. Actually, when we removed the bureaucracy of some of that contracting and allowed people just to work with others to work out what was best at that time, they did some remarkable things, and I'm pleased to say that some of that was picked up and highlighted by SSSC and Care Inspectorate as good practice.
At 166 you talk about prisons, and I don't think we need to hear you in relation to prisons, but you then talk about the current position and what could have been done better. Can I ask you to say something about paragraph 171?
So in thinking about what lessons we could learn, I think that is fundamentally important. And I think probably social care is better understood already as a result of the pandemic, but actually taking the time to have really understood the diversity, the number of providers, what social care is, what it does, how it impacts people's lives, and to have that approach to guidance would have made a huge difference to those supported and to the workforce. We're not organised like health. That health directive way of working was never going to work for us. And that's, I think, one of the big things that we could learn. I think the independent review of adult social care actually talks about that. So if that came in 2020, as the government were asking that to be looked at, and it's one of the things I think that Mr. Felix says in that report, that actually, while it's often understood as care homes and care at home, that actually it's a massively diverse sector and we need to learn more about it.
The last sentence in that paragraph, 107.1, the Scottish Government should not have thought they could treat social care like they could treat the health services. We, of course, this inquiry, one of its terms of references includes pandemic planning. Would you consider what you highlight in that sentence I've just read part about to be, I don't want to put the word failure into your mouth, but it's difficult to think of an appropriate synonym. Is it a failure of pre-pandemic planning that there appeared to be no appreciation when the pandemic struck and an urgent situation was obviously present, that there was no planning for care homes? Or the exigencies of care homes.
Yes, I think that. Well, I guess if we go to a root cause, then there was a failure to understand, and that did lead to an awful lot of work in terms of sorting out guidance that potentially could have been thought through earlier and prevented some of the disruption happening in what already felt like a fairly chaotic situation at times.
Yeah, thank you.
Do you still have your guidance tracker?
No. No, but some of the guidance is still in place.
Yes. Okay, thank you very much. Those are all the questions. Except one, which we traditionally ask at the end. We've tried to cover as much ground as we could in your statement. Is there anything important that hasn't been covered that you West Lord Brailsford about?
No, I think the statement is full, and I thank you for your time this afternoon.
Thank you very much.
Mr. Dickenson, I'm very grateful.
Okay, thank you.
Yes, well,
thank you.
That's the end of this mini session of 3 weeks, I'm glad to say. And we'll be back, I can't remember, is it October?
16th.
Wishful thinking. April the 16th, I think. 16th. Very good. Thank you very much.